Hey, everybody. Welcome to today's training session on panic subtypes and exposure. I know I started it live at exactly 12:30, 11:30 Central Time, or wherever you're coming to us live from. Um, so I'm glad that you're here with us. I'm not going to start officially quite yet. I'm going to give us another minute or two as people try to get logged in and set up. I guess I'll remind everybody again at the end, but I'll mention it now. When this session is over, if you wish to earn CE, please log back in at the site where you registered for this session. You need to log in again, complete the brief CE evaluation, and then that will lead you to the CE certificate. So we appreciate you doing that. Again, I'm going to remind you all again at the end. So I thought I'd bookend the session with that. So let me get started officially. So this is the next one in our series of trainings that has been generously supported by Better Living Center for Behavioral Health. It's been my pleasure to be a part of their board of directors, board of clinical advisors, and in doing so, put together this series of presentations on different clinical matters. The one today on panic, subtypes, and exposure is a useful one because I think there's a lot of assumptions about how treatment goes for panic. And this is a nice way to kind of ground everything and also to highlight that there are varieties of presentation of panic that are worth knowing about because it allows for us to really talk about these things with our clients. And also, I think as we understand panic more clearly, provides an opportunity to really understand the way that clients experience these symptoms and the varieties of ways that they experience it, because it's a lot more than I think what is the standard assumption for symptom presentation. So here's our little overview of my structure for what today is going to look like. So a little brief overview of panic itself, what the existing evidence-based treatments for panic are, what the subtypes of panic are, and the connected interoceptive exposure approaches that you might employ for each one. We're going to talk a little bit about some of the limits in the research on treatment. You'll be surprised to hear that on the one hand, if you follow the anxiety disorder literature really closely, panic disorder is one condition where there's not been quite as much activity as there has been for a lot of other psychological conditions, which is a little surprising when you consider that the depth and generalizability of the available research is not quite as much as you might have been led to believe. So I'm going to talk a little bit about that at the end. We're then also going to talk about medical conditions that can sometimes prompt panic. So for those of you that really specialize in treating anxiety disorders, you may appreciate that occasionally cases like this come along. I feel like now it's worth highlighting this for a broader audience, assuming that some of our registrants are not anxiety specialists, but are generalists. And as generalists, you may hear about people coming in with panic conditions that are a consequence of some medical condition. There are a couple that this is expected for. And so I just, kind of an awareness raising, consciousness raising kind of element that we have as part of today's session. And then we'll have some time for some questions. So that's our little overview. And so let's get started on the content. So a little reminder just historically. So panic disorder, first of all, very highly prevalent anxiety condition, both in outright disorder level diagnoses. So to remind, panic disorder, to get that diagnosis, means that the individual has a panic attack at least once a week or 4 times in a month. That's generally the agreed upon criteria, and with accompanying anticipatory anxiety between panic attacks for when the next one might happen. As a psychiatric condition, it's associated with very significant disability. And for many sufferers, there is avoidance that leads to agoraphobia. So panic with agoraphobia obviously is sort of the signal debilitating condition with its roots in the actual panic attacks. It's characterized by sudden and intense fear associated with rapid sympathetic nervous system activation thoughts of either death or loss of mental control or both. So statements that people might say are things like, I felt like I was going to go crazy or I was losing my mind, primarily because as they're experiencing this, and they also see that the world around them is unchanged, they also see that they are not actually going to die. It feels peculiar. It's very out of context. And the picture there, that's just the academic in me couldn't resist. So the origins of panic, the name comes from the Greek god Pan, who had a number of different powers, but one of them was that Pan could shout so loud and with such fearsomeness that it would literally scare his victims to death. And so panic comes from the Greek god Pan. So there, little something for you. If you learn nothing else today, now you know about Pan. So I know on the screen, this might be a little small for you. If anybody's interested, I'm happy to send you the article. But it's worth understanding that the model for how panic emerges in sufferers can be traced to a few different things. One of them is an early loss of control experience, one where they are more likely it's a loss of physical control and the inability to understand it properly becomes fearsome, and a co-occurring anxious temperament. That's sort of two readily agreed upon individual characteristics. Now, for example, an early loss of control experience for some sufferers, in fact, in my anecdotal experience, many panickers that I've seen can trace their first panic attack to an early occasion, most likely in their teen years, where they experimented with cannabis. And so for those of you who may be familiar with this, when you try cannabis or if you routinely imbibe, you know that the experience is one that you will feel for several hours afterwards in a fairly pronounced way. So people who have panic and who might have an anxious temperament the first time that they try this, they feel that they can't control it and it becomes frightening, and then that leads to some difficulties downstream. The next phase there, where it comes to people having actual panic experiences, well, there are two elements here that are worth paying attention to. One is anxiety sensitivity. I'm going to talk more about that in my next slide. And the proneness to respond anxiously to CO2. There's a model of panic that they call the false suffocation alarm. There's pretty decent support for that theory. There's some limitations in it, but overall, the idea is that individuals with panic are more sensitive to CO2 in the atmosphere. And as a consequence, when there is minute increases in CO2, they may begin to feel as though the availability of oxygen is lower. And as a consequence of that, one's body reacts to CO2 inhalation at the neural level, and it leads then to anxious arousal. Now, if you want to understand the comparable sensation, you'll all recognize the idea of saying to somebody, "It feels stuffy in here." That remark, saying that it feels stuffy, is basically your brain responding to the fact that there is more CO2 there than you are accustomed to. And so there are occasions where CO2 can be much higher and would be worth asking someone about if they report that they have panic. For example, do you find that you have more panic sensations in the summer in high humidity climates? Well, here we go. This is one of those occasions where during high humidity, there's more CO2 available in the air. And as a consequence, the increased risk of panic. My business partner, who has a great knack for creating the conditions for panic and in the office, will bring in a humidifier and a heater and then close his door and leave both of those on for like an hour and meet with people in the neighboring office for a little bit before having an appointment with someone to do more like a graduation level exposure exercise. So one person commented in the chat that they'd like the article. I'm happy to send it to you. Please email me the request, and I'm happy to send it to you. My email address is deanmckay.phd@gmail.com. I'm going to put it in the chat. Feel free to request that, and I'm going to reference another article during the talk today, so if you would like that, I will be happy to send that one as well. Okay, so that process of activating panic sensations, and then in my the far right section, I list out how this unfolds in biological correlates, the HPA activation, panic activation, and then eventually the cessation of panic. So that whole process that I just laid out, other than the early onset and early experiences, the phase 2 and 3, it's like a 20 to 25-minute experience from the initial experience all the way through to cessation. Okay, so anxiety sensitivity is a core concept here. And I apologize, I should have learned my lesson. When I upload these, it always throws off the formatting a little bit. So let me start with what you can't quite see on the slide. So anxiety sensitivity is a key construct associated with panic. It's easily assessed, by the way. There is an 18-item questionnaire that is the most widely used measure of anxiety sensitivity. It's called the ASI-3. It's super quick to administer. It's not proprietary, so you don't have to purchase it. If any of you are requesting materials via email from this presentation, I'm happy to include that measure with it. And anxiety sensitivity, what's nice about assessing it is that it gives you a baseline of how much the individual is basically paying attention to their internal experiences and reacting with some fear when there's a change in the physical sensation. So note that it's not that anything has to increase like via sympathetic arousal. So for example, if somebody's concerned with heart rate as a central feature of their panic symptoms, they will be noticing their heart rate if it goes up or if it goes down as a source of alarm. That's the main thing. And so anxiety sensitivity denotes an increased level of interoceptive awareness, which we put in the category of a fear of physical sensations. Many panickers will then also report that they're concerned that other people will notice that they're anxious. So that's the fear of publicly observable symptoms. And then, of course, they're also concerned about their mental state, as per what I said a slide ago, which is that people are worried that they're losing they either are having loss of control of their mind, or that they're going to die. So that fear of loss of cognitive control is a third factor. So as I mentioned, the main, most widely used instrument for this, the ASI-3, it's 18 items, and it has 6 items for each of those subscales. And so you get 3 broad dimensions. They all form a total score of anxiety sensitivity, and you could track it over time. There is a lot of research on anxiety sensitivity. As a construct, it first was articulated in the mid-'80s. It quickly took hold as an important concept in understanding anxiety disorders, and the research on it has borne that out. It is widely associated with really all the other anxiety disorders. So panic is the one where people score the highest on this measure, but individuals with social anxiety, generalized anxiety, phobias, people with trauma. So as we walk outside of the anxiety disorders, trauma survivors, people with OCD, they all have high levels of anxiety sensitivity. Interestingly, given the fearful responding due to interoceptive monitoring, there's a lot of research that shows people with chronic pain conditions tend to have high levels of anxiety sensitivity. And also there's a fair bit of research that shows that people who excessively use and abuse substances can develop high levels of anxiety sensitivity. Now, you might wonder, why would that be? Dr. McKay, after all, you just said one slide ago that sometimes people develop panic after cannabis experience. Why would someone with substance use and abuse have high levels of anxiety sensitivity? Well, I'm happy to explain. Here's why. Anxiety sensitivity is a reaction to what is otherwise normal variations in your physical state. So let's say in the course of a day, your heart rate may be a little higher at 4 in the afternoon than it is when you first wake up. Your respiration correspondingly may be a little higher at different parts of the day than at others. And that normal variation we have come to accept. And you may even say, like, oh, wow, I always have a little bit of fatigue in the late afternoon. I always kind of feel tired then. The reason why substance abuse shows up here, and I know this is not the purpose of the talk, but allow me this sidebar for just one more second, because it is relevant to the kinds of things you might assess for when you meet with someone reporting panic. So here's what happens. So people use and abuse substances, and if they do so to a point where it's a target of treatment, anxiety sensitivity may become relevant because what was ordinarily previously a tolerated routine stressor is now harder to tolerate. So the idea is not so much that the individual with substance use and abuse necessarily, they could have, but not necessarily had high levels of anxiety sensitivity at the start of their substance use, but that the use of substances drove down their tolerance of ordinary stressors. And so now their anxiety sensitivity has gone correspondingly up. Okay. Now, that may be the topic for another talk sometime on the association between substance use and abuse, but I'll leave it at that for now. If you're interested in research on these last two that I listed here, chronic pain and substance use or abuse, check out for the chronic pain research by someone named Gord Asmundsen. I will put it in the chat. And for the substance use and abuse research, check out research by Sherry Stewart. Gord is in Canada at University of Regina in Saskatchewan, and Sherry Stewart is at Halifax University in Nova Scotia. Dalhousie University in Halifax, Nova Scotia. Okay, so evidence-based treatment for panic. Where is the evidence? Well, first of all, the largest body of research on the treatment for panic is from the CBT literature. Now, if we want to be balanced, look, I'm a CBT-oriented practitioner. I feel that there is a very compelling body of research using that set of procedures. I will highlight, though, that there are not that many systematic investigations of other therapeutic approaches. So we will declare that panic treatment using CBT is the primary evidence-based approach. But I want to be balanced and let you know that that is because it is based on the preponderance of research support in the absence of systematic research using other methods. Now, within CBT, the approach that has the highest efficacy, the one that seems to account for the largest amount of change in actual panic experiences, is interoceptive exposure. So interoceptive exposure, in a nutshell, is where you as the clinician go to activate the specific physical sensations of panic that the sufferer says is most troublesome. So that's our starting point for how we go about treating this. Now, that leads to some challenges. Like, well, what is it that you're going to do to bring about those physiological reactions, and how can you do it safely? So it immediately raises some questions that many clinicians need to wrestle with. So let's think about this from the different kinds of subtypes. Here are the identified subtypes of panic. Other than the medical condition induced one that is last, the first 5 that are listed here have been consistently identified in the empirical research. The source for this, by the way, a really nice review done on this back in 2009, and there's been good replication of these subtypes since then, but Kursansky et al. In the journal Depression and Anxiety really laid out the empirical support for those 5. The medical condition induced form of panic that we've called attention to separately is really understood in the medical literature, but most psychological-based research has not really focused on it as much. So I'm calling attention to it because I'm aware of this body of literature, and I think it's an important one for us to think about. But these other 5 have been really consistently demonstrated in evidence-based research on the ways in which this manifests. So let's think about the first one, and this is a little demo time. Many people are familiar with interoceptive exposure for the respiratory subtype. So in the respiratory subtype, the person is concerned with shortness of breath. That's the main concern. And, and it's correspondingly associated with other physiological indicators. So the stage is set for it by increased heart rate, but the sufferer may not notice the heart rate as much as the fact that their breath rate is increasing. And as it increases, they start to worry that they are somehow going to suffocate. Remember that false suffocation alarm? Well, here it is. This is the main one. Now, the method for treatment, the interoceptive procedure, is the one that to me is the most potent one. So I'm leading off our actual intervention phase with what is, in my view, the most potent of the interoceptive exposure methods, and that's the hyperventilation challenge. So a little historical note for a second here. The hyperventilation challenge is something that has been demonstrated in the lab numerous times. So there's a lot of different laboratory experiments showing hyperventilation methods provoke panic in the lab, and there's a lot of different ways that you can do it. I will tell you now that if you do hyperventilation with your client and you do it together, whether it's live or via remote treatment, you could do it via remote treatment. I have not yet had anybody panic during a session. What instead often happens is the description of what you're going to do provokes a fair bit of anxiety. People get very apprehensive because the description sounds a little scary. When you do the actual interoceptive exposure with people, there will be some apprehension, but upon cessation of the task, there's usually not a lot of anxiety. That has been my experience personally. Now, maybe some of you will have a different experience, but I'm here to tell you I've done it. I must have done this with like 300 people over my 30-year career, and I've yet to really have anybody panic in my office. So I said demonstration. You don't need fancy equipment to do the hyperventilation challenge. We will do it with, I'm going to use my grocery store lunch bags. I'm kind of partial to White Rose brand, so I'm putting in a little product plug here for White Rose brand lunch bags. I think this package of 100, so I could do 100 sessions of interoceptive exposure. Well, really 50 because I usually do it with the client. So 50 sessions for, I don't know, I guess this was $2. So $2 of an investment for 50 sessions of exposure. Feels like a pretty good deal. I think prices might have gone up a little bit due to inflation. This is not the newest bag. But here's how it goes. I'm going to do really the demonstration. The mechanics of this to me are so important that to just simply say to you, hey, do hyperventilation with your client using a paper bag is not really enough. So here's how I like to do it. So I like to do it where I very clearly open the bag fully for the client. I like to stick my fingers into the bag up to my second knuckle. And the reason why is that allows me, now for some of you who have smaller hands, you may need to go out to the last knuckle, but I want to have the opening to the bag in such a way that when they place the opening of the bag to their mouth, the outer edge of the bag covers their nose. Now, why would I want to do that? The reason why I want to do that is because I want all of the breathing that is about to happen to be through the bag as much as humanly possible. And what I'm cognizant of, and I'm raising all of your awareness about this too, is that our clients who have anxiety are exquisitely skilled at avoidance. They're not intending to interfere with the process of therapy. It's that this is something that comes naturally every single day. And our task is to interfere with that naturally occurring avoidance. So one way that someone might avoid this, now for you people, what I'm going to do, I'm going to burn another bag on this to show you what I mean, okay? That's how confident I am. Other than, so it's an additional, what is it, a half a cent I guess, if my math is correct, on wasting a bag. So let's say you allow the client to just open the bag. They make a little opening. I've had people do this. They make the opening like this. They stick it here. Their nose is exposed. So while they're breathing here, they can also breathe here. Well, that's not really in keeping with the spirit of the exercise. The idea is for all of the breathing to happen through the mouth and nose if they're inclined to do so. Now, once I instruct people to do that, I want to make sure that when they breathe in and out of the bag, they have the hole small enough that the bag opens and closes. The reason why is because it has to be CO2 that they're getting. If the bag isn't opening and closing, but they're breathing, then they're just breathing. They're breathing fast, which may accomplish the aim a little bit, but it's not really what we're going for. So we go like this. So I'll demonstrate it. Now, time to actually do the exposure. How I like to do it personally. So again, this is all interoceptive exposure, hyperventilation challenge, as Dean McKay likes to do it. Now, you may have your own style. Feel free. I'm just illustrating the way that I like to do it. So what I also instruct people on are two more things. One, I'm going to do this now. I'm going to stand up. So let's see, I'm going to adjust the camera. So in standing, what you can't see is that I instruct the client to stand with their feet placed directly together, heels touching and front of their shoes touching, or feet if they're coming to me remotely and they're at home and they don't have shoes on. The reason why is I want to minimize their surface contact with the floor. Now you might be thinking, why are you going through all the trouble of that? This is the part of our presentation that we call foreshadowing. You will see soon. And I'm going to describe it in a moment. So in the actual hyperventilation part, you negotiate with the client, how long can you tolerate this? You describe what you're about to do, which is do this with the bag, and it's at a rate of about 30 breaths a minute. Now, if you're not oriented to how many breaths a minute you usually take, you know that it's not 30. Most people in a typical normal breathing rate, not relaxed, not about to go to sleep, but not fearful, probably like 8 or 10, maybe a little less, maybe a little more, but in that neighborhood. So 30 breaths a minute is fast. I like to do it with clients because I want to pace them. So I'm their pace car. I give them the rate of breathing for this exercise. So I put this to my mouth with it covering my nose, and I start breathing in and out. Right? So we start doing that. Now, let's say if I negotiate with the client that they feel they can tolerate this at a rate of roughly 30 breaths a minute for 2 minutes, we'll do that together for 2 minutes. Now, I'm not going to do that 2 minutes now. You get the idea, but you would have it to your mouth. Now, if as you're listening to me, you've never done this before, I recommend doing it. Do it on your own once to get a feel for what it's like. Make sure you're medically okay to do this, which, by the way, you should do with all your clients anyway. Make sure that they're medically cleared for a physical activity like this in your office. That's an important criteria. I recommend this for all of you as well. Make sure that you can do this. If you regularly exercise or do things that are physically demanding, you're probably okay. But if you're unsure, go to your doctor and make sure it's good to do. Practice doing this. The reason why it's useful to do this is because it's a little bit surprising how long 2 minutes will feel when you're just simply breathing into a bag. The other thing that you should alert your clients to is that this part of the bag, when they do it, it will not be unusual for there to be some spittle that forms there at the end of 2 minutes. You can go longer than 2 minutes, by the way. You can go as long, I've done it with people as long as 5 minutes. That's a pretty advanced level. For 5 minutes, you do 5 minutes, there's going to be a lot of spittle here. People get really short of breath. Now, the standing part. Why standing? Why with your feet close together? So when you get done with this exercise, as a clinician, there are some things that you can say, or you could stand silently, but one of the things that you want to emphasize for the client during that respiratory interoceptive exposure is you want them to really pay attention to the sensations. You've just done this exercise that has them very short of breath. So have them really focus on it. I always have people do two things. One, they take the bag away and I say, okay, now close your eyes. Keep your hands at your sides and close your eyes. Now, usually what happens when people do that is they feel very wobbly. They feel wobbly because their feet are pressed close together. And so the world is starting to kind of spin a little bit and they move around like this a little bit. They usually don't fall down. Again, might check with your clients about how much balance they have or keep a chair handy in case that they do lose their balance. Again, referencing my own experience with this with clients, I have not had anybody fall ever, not once. But I can understand why you'd want to exercise caution, and I would recommend that because I still do that myself. Okay. The other criteria with this is I ask people to just kind of think about when they finally feel the sensation go away. So they keep their eyes closed, they focus on the dizziness, they focus on the shortness of breath, they focus on the physiological arousal that has happened, which when you do this, even though this was the respiratory subtype, inevitably heart rate will have gone up. Also, what might have gone up is changes in their physical sensation in the extremities, like in their fingertips, in their toes. They may feel a funny sensation in their armpits, warmth kinds of sensation, maybe some perspiration. All of these are normal reactions that they should have, and you can increase the hierarchy. You can also instruct the client to do this between sessions. So once you practice it with the client during the session, you could do it a couple of times too, by the way. I've done it as many as 4 times in a session with someone with hyperventilating. You don't have to go through a new bag every time, by the way. Remember, you spent $2 on this. You want to make it last all 50 exposure sessions. So that would be the model of intervention for the respiratory subtype. Now, we're going to come back to the hyperventilation soon, but let's look at the premise behind it and the process. So I described how you do it. Let's talk about the rationale, because you want to educate your client about this. You're going to convince them, we're going to practice panicking in the office. They're not going to panic, most likely. And you need to be able to be armed with a good reason. Like, why should we do this? Why would I trust you to do this thing with me? Okay, well, here's why. People with panic are known to react to CO2. We're going to practice then diminishing the reactivity that you have to CO2 through deliberate infusion of CO2, which we can do economically in the office. That's your explanation. You can get into some more discussion about it. For those of you that may have a pulmonology kind of background, you may get into some things related to alveoli and other things in the lung system. But basically, that's the bottom line. And you create a hierarchy related to hyperventilation. You can vary. I did have clients in the past where the rate of breathing was an issue and not the amount of time. So we started out where the breathing rate was slower, and we worked our way up to a more rapid rate of breathing. So you can move around on what the hierarchy might be for this. To really put a sharp point on this, a woman who I've been working with recently, for her, the sensitivity to hyperventilation was so great that the first time we did it, she did it for 30 seconds. And she found that she had minimal reaction, and we moved up to 45 seconds. And then she worked on 45 seconds between sessions, and it took a week before we got up to 2 minutes. So with some people, you start slower. You just kind of meet the client where they are. But as long as you can introduce it and get people started on it, you will go a long way with this. So I'm glad I wanted to devote a lot of time to this particular interoceptive exposure procedure, and you'll see why in a minute. So the nocturnal subtype. So the nocturnal subtype is a particularly upsetting one for clients. It's not really more challenging to treat. It's just that the occasion upon which panic happens is distressing. And so we need to understand the 4 stages of sleep. And there's a particular stage of sleep, specifically phase 2, where your respiration slows down dramatically. Now, remember what I said before. Anxiety sensitivity is where the individual is monitoring physiological changes. So that means things when they go up could be assigned a certain amount of fear, or when they go down. When your respiration starts to drop in phase 2 of sleep, for some people with nocturnal panic, that will prompt that sense, maybe I'm suffocating. And people go from falling deeper into that deeper stage of sleep to being bolt upright, panicking, full on panic attack with an intense level of physiological arousal, high levels of usually sweating. It would not be uncommon for a client with this particular subtype to need to change their sheets and change their pajamas because of how intense the arousal is. And then they're awake for a while. So it is an incredibly disruptive subtype. Loss of sleep, for those of you that have sleep disturbance, you know that being awakened in that way and then being awake for a while afterwards is very disruptive to your day-to-day life. So for that one, the corrective process is to address this respiratory element. The idea is that if you practice hyperventilating while awake, you gain a sense of mastery over it. You also demonstrate physically that one can have this CO2 infusion without undue adverse consequences. There's one other option, by the way, that I didn't list here, but it's worth highlighting. In some individuals with anxiety disorders, relaxation has the paradoxical effect of provoking anxiety. We sometimes think of it as a almost pathognomic sign for generalized anxiety, right? People who worry is where it has been most clearly and initially documented, where the act of practicing relaxation, because the person starts to feel a loss of control, a loss of vigilance, they get anxious. Well, kind of something similar could happen here. So there's another option if you wanted, and you practice this with someone, if it's abundantly clear that it's that drop in respiration that's provoking it and not some of the other aspects of the sleep process. You can practice, let's say, diaphragmatic breathing, where the task is to drastically slow down the pace of breathing as an exposure procedure. So you can use relaxation in a paradoxical way. I prefer to start with respiration and exposure via hyperventilation first, because it is the most generalized approach. The other preparatory process for the nocturnal panic subtype is to educate people about all the phases of sleep and include in it things that are normal processes that sometimes people react with alarm to, which include that one minute phase of sleep where if you awaken during it, there is sleep paralysis. So there is a phase of sleep where being unable to move is a normal part of the process. And if you wake up during that time and you open your eyes, it is not unusual for people to have what are called hypnagogic hallucinations, which is like kind of like a light kind of experience. There is sort of a different color kind of experience. People report different things that look like they're seeing flashing lights and other really kind of troubling perceptual experiences. So it can be quite alarming for people who wake during that phase and experience hypnagogic hallucinations. And it can also be the prompt for some panic. Do you want to kind of get a handle on, well, where were you at in the phase of sleep before you do this? But one of the leading ways to do it remains, in my view, hyperventilation challenge. Okay. The non-fearful subtype. So this is a little bit of a confusing one. And so, seeing it listed there, the name I think for that subtype is also a little strange. But we really should think of it in a little bit of a different way. I'll reference it in the way a client of mine described it. Some of you may be familiar with the children's book, The Princess and the Pea. I had a client who had panic, who described his panic sensations as like, I don't feel great. I feel kind of, as he put it, itchy. And he'd be like, and I don't like that, and I have to get out, right? And he really kind of talked about it that way. He was actually a little self-deprecating about it. And he said, look, I'm kind of like the princess and the pea. I don't like any discomfort. And so our process was to get used to tolerating a range of ordinary stressors. And so one of them, for example, and why I chose the picture that I did, I had him practice putting sand in his shoes and walking around during the day with a little bit of sand in his shoes. Now, I've described this other times. People usually go, "Oh, that sounds horrible." And yeah, it is. It's unpleasant. But the question that we should be asking ourselves is, even though we would not like it, could we tolerate it? In other words, is this an ordinary physical disruption that we'd be able to go on with our day? Or would it be so disruptive that we'd be like, that's it. No, I must stop. I cannot tolerate this. Now, the reality is that if you've ever gone to the beach, you know that at least for the drive home, you probably have sand in places that you don't like having sand. And you tolerate it. You drive home, you may even be talking to people that are in the car going like, wow, it was a great day at the beach. We got in the water and I feel all that salt on me still. I can't wait to get in the shower. But boy, what a good time, right? So by way of similar process, we could do that here. So the idea is to look for what kind of discomfort is prompting avoidance of situations and then practice tolerating that and possibly other physical stressors. That's basically how it goes. So the interoceptive exposure is more tactile or everyday stressor kind of experiences rather than the activation acutely during the office visit. Okay, cognitive subtype. Remember, I said that there's a cognitive subtype. Well, one of them that you could do here that I've done, and I put pictures of the stimuli objects that you might use. Again, low cost, a little more expensive than our paper bag exposure, but you can get a lot of mileage out of this too. What I have done historically, you could do a exposure to physical sensations that are disorienting in nature, and it leads to one struggling to organize their thoughts. So one that I like is the strobe light along with 3D glasses. The 3D glasses that I prefer, I've learned that there's a bunch on the market. The ones that you want are the ones that really create kind of a prismatic effect when you have them on without some kind of 3D oriented film to watch, right? So if you just had a set of 3D glasses on and you're not looking at anything except just the room around you, it looks a little strange, blurry. And if you look directly towards lights, there's like a prism effect in the periphery. If you do that, and then you also do it where you darken the room, you turn on a strobe light, it's very disorienting. There are other ways you could do this. I have a friend who used to like to do things like with loud heavy metal music. So, you know, if you like Iron Maiden, you could bring in some of the greatest hits and play those for your client in earbuds and then have them try to think of things. And the idea is that they're practicing the idea of loss of cognitive control. And for you, the clinical activity for you is to comment on how it's evident that the person is losing their mind. It's a little foreshadowing for my next training session on imagery. So you might engage in some imagery around loss of control. So that would be a persistent process that undergirds it. It is possible that a big part of what is happening here is due to anxiety related to a part of panic experience of depersonalization or derealization. And there is a small body of work on experimentally inducing depersonalization in the lab. And one line of work doing so has been with strobe lights and 3D glasses. So that's the cognitive component. The vestibular type of panic is based upon dizziness. Now, you could do it in two ways. One, so the premise is that you're correcting a disruption in the semicircular canals of the inner ear. So let's be clear, vestibular is as opposed to someone suffering from vertigo, which, by the way, medical treatment for vertigo, in addition to people taking different steroids and other medications that are hypothetically supposed to reduce different kinds of inflammation, it does also involve some measure of feedback. And so the act of lying down that people with vertigo sometimes rely on as a means for alleviating it actually can paradoxically increase it. And so you do want to help people to not avoid the process of trying to accommodate it because, that can be problematic. But in the office, again, probably use equipment that you have on hand. If you have a swivel chair in your office, then you can have the client sit in the swivel chair, and your job would be to spin them around. Now, I like to give some instruction on this that's very granular. It's not really just spinning someone around like a child trying to attain dizziness. People generally try to avoid feeling dizzy. That's been at least my anecdotal experience. And so I give people some specific instructions. What happens when you spin, you naturally track. So your eyes naturally try to fix on an object, and then you move and you fix on a different object, and then you move and you fix on a different object. So as you rotate, you keep fixing on an object. I ask clients to try, and I know that they can't fully do this. I say, try not to fix on an object. Just try to stare straight ahead, right? In other words, I want to have more dizziness. I want to provoke more dizziness. So as I spin the person around, and I don't spin them that fast. When you first do this, most adults don't require that many rotations before they start to feel dizzy. They won't know they're dizzy, by the way, until they stand. We have to be aware of a process here. If you do this in the office with someone, there are two elements to it. One, for the hierarchy, you're kind of experimenting. And I always start out really modest, and I'll say, okay, let's try it where I spin you 3 times. 3 rotations. So 3 rotations, and not at too fast a pace. I ask the person, keep their feet up, spin them 3 rotations. And then when they're done, I say, when on the 3rd one, I want you to stand up. So similar instructions to the hyperventilation. Stand up, keep your feet close together, arms at your side, close your eyes, and focus on the lightheaded feeling. In other words, I want as much of an enhancement of the interoceptive experience and not have distractions by other things. Again, what you say or don't say during that time is a little bit dependent on what the feared consequence of getting dizzy might be for the client. So that's at your discretion. Again, we'll probably return to this in a couple of weeks when we get together again for imagery. Okay, so these things that I just talked about are all mainstream approaches to interoceptive exposure for panic in the majority of the population of panickers who have been studied, which is basically primarily white adults between ages of roughly 16 to 64. Where are there limits in this literature? Well, here are a bunch of them. We recently, in my lab, indebted to my graduate student, Anna Rabasco, who put this together. We recently did a pretty comprehensive survey of the available research on CBT approaches for panic, and we found that there's some very big gaps. One, we don't have great data to suggest that this is efficacious with adults over 65. We suspect that it is, but the data is not really quite there. There are massive limitations in the degree that these studies have included people of color. So can we really generalize to people of color, to sexual and gender minorities? Again, don't really have good evidence on this to generalize to different groups. And we also don't have a lot of evidence on how to approach this for medical conditions that can sometimes prompt panic symptoms. It's not that we have none, but I want to shine a light on that because it is the one that at least comes closest to the other areas we've talked about today. So I don't want to pretend that we have available to us models of intervention that we can clearly translate to evidence-based treatment for the other underrepresented groups. There are some ideas out there that have been tested in limited ways. And in the meantime, I will cover the ones that we do have some data on, and again, with majority populations. So medical condition-induced panic. It's where you can do exposure for these conditions. There are some limitations and cautionary notes that we have to think about. And there are 2 illustrative examples that I want to highlight. One that has a fairly, a larger literature, not necessarily a big literature, but a larger literature. It's known among epilepsy experts that people who suffer from that condition can have panic attacks in anticipation that they may have a seizure. So that's one group. The other that is less well investigated, mainly because the diagnosis itself, the medical condition, is also less easily achieved, is postural orthostatic tachycardia syndrome. In a nutshell, if you look at each of those words in isolation, you probably can glean what it is. It's basically where people who have sudden change in physical position can have either increased heart rate or change in vestibular reactions and have loss of balance, and then can be translated for those sufferers to panic symptoms. Okay, so panic due to epilepsy. The primary fear activation is when most people who suffer from epilepsy will report that they know when they're about to have a seizure. They feel what's called an aura. By the way, that aura sensation, I didn't say that word, but if you look at the early slide when I introduced this topic, most panickers will say that they get a little bit of an aura. And so that aura sensation is just like a funny physical sensation where the individual is kind of alerted, like, uh-oh, something's going to happen. I can't stop it. Here it comes, right? And so people who suffer from epilepsy sometimes will experience this. Now, the Epilepsy Foundation, by the way, has noted that some people reporting panic are actually having seizures. So this again returns us to what I mentioned at the beginning of our presentation today. Anytime someone comes to the office reporting panic, one of the first things you should ask about is whether or not they've recently had a medical evaluation. Often they have. If they have, you want to speak to their medical doctor, find out about their risks and any things that might stand in the way of doing exposure with them. And if they haven't, of course, then send them for a medical workup before you do exposure. For this form of exposure, I don't feel as conservative about medical evaluation for some other exposure procedures, but for this one, it's a little special in how it goes, not just for epilepsy, but for panic in general. Okay, now, also panic due to epilepsy, probably not candidates for the strobe light-based exposure. So if they report the cognitive variety, you're going to have to rely on something else most likely. You already know this probably if you watch enough television like I do. You know that some shows and some episodes within series will have a warning for some of them where they'll say flashing lights, be warned, because we do know that sometimes people have seizures due to some video-based presentations. But you can do exposure for epilepsy-related panic. You just have to be more cautious about it. Panic due to POTS, that postural orthostatic tachycardia syndrome. The primary activating event is any lightheadedness. You can provoke lightheadedness safely in individuals with POTS. The only real distinction is make sure that if in the event they get too lightheaded, that they struggle to tolerate it, that they have a chair or a couch right alongside of them that they can gain their balance. You may need to go more gradually, so it may take a little longer. This last challenge, number 2, that I listed is more anecdotal, but I did find some literature to support it. So, take that with a grain of salt. It's a little bit like, hey, here's what Dean McKay said. He said he found some literature on it, but I'm also telling you from anecdotal experience with clients is that POTS has pretty substantial agoraphobic avoidance. And part of the issue is that people who have POTS are worried about becoming so lightheaded someplace that they can't get to a safe spot, that they need to rest or find a place where they can wait out their POTS reaction. And it's just more upsetting and challenging to do it if you're alone than if you're accompanied by someone who's a trusted companion. And so that leads to some of that agoraphobia reaction. Okay, so a little bit of housekeeping. Remember, I mentioned at the beginning, please make sure you log back in to finish the CE survey and get your CE certificate. That's all the material that I wanted to cover today. I left some time for us to go through some Q&A. So I'll remind you where we're at here. If you go back to the home page where you registered for this talk, Better Living Center for Behavioral Health, they've been so great in sponsoring this work. I'll remind you, do a little bit more of a plug for them. As a reminder, they offer intensive outpatient, partial hospital treatment, and also individual treatment for anxiety, trauma, and OCD. So please look to them as a great source for treatment for clients who need more high-level care, or if you wish to refer them, they do treat in 15 different states remotely and a province of Canada. So here are the trainings that are out there already on the webpage. You can view those recordings now from the prior ones. This one, if you want to tell your friends, will be available to view the recording in 3 days. And come back and join me for our grand finale in my training tour on May 17th, where we'll get to talk about developing imagery as an accompaniment to exposure therapy. Something that, like with all of these, I'm very much looking forward to. The imagery thing, I'll just give you a little teaser. Imagery provocation is what got me into anxiety disorder treatment. I'll tell the story of how that happened when we get together, but I will tell you now, it was not by doing exposure. It was in a social setting. All right. So thank you all for joining us today. I'm happy to field any questions you might have. Put them in the chat and let's hear it. Okay, so the question, thank you very much for the compliments. So what kind of interventions could be of help to someone who's not suited for this kind of exposure? Okay, right. So let's say there's a medical limitation or some other limitation that makes the person ill-suited to exposure-based treatment. So there is a body of work on cognitive therapy for panic. And cognitive therapy for panic addresses specifically the automatically occurring thoughts that go with the physical sensations related to panic. So in other words, the appraisal model, and by the way, one of the most frequently cited articles on panic was written by David M. Clark in 1986. It's called The Cognitive Model of Panic. It's a widely available paper. I think you can get it pretty readily on Google Scholar. But in that article, the description that he lays out there of how to conceptualize panic from a purely cognitive perspective does not include exposure. It includes primarily addressing the thoughts that go for, what is the catastrophic consequence that the individual believes will happen due to increased heart rate. So the empirical literature on this is a little fuzzy, and I'm going to reference a prior talk where the issue about exposure and to the degree that it is baked into certain cognitive interventions is at play here. There are usually some kinds of what we call behavioral experiments that look a lot like exposure. And so at some point, the client will need to practice experiencing the sensations somehow. The provocation may be less intense than what we do, let's say, with hyperventilation or with expressly provoking dizziness. But nevertheless, it does seem most of the literature suggests that there will need to be some modest level at least. But that would be the other component that you might see. Other questions that you guys might have? Any comments? I'll give it another minute or two if somebody's typing something kind of lengthy. I see 10 of you in attendance. I appreciate you all joining me. I know there's like about 70 people or 75 people registered for this that I guess are going to be viewing the recording later. But the 10 of you that came here to see it live while it happened, thank you so much. Thank you, Richard. I appreciate it. Well, I see we're just about out of time. Okay, here we go. Rodrigo has a follow-up. With some conditions such as obesity, could this type of exposure be advisable? Okay, so this question goes to this. I'll use this as our concluding question. And thank you for that, Rodrigo. That's a great question. And most clinicians appropriately are sensitive to medical conditions that one might think could be barriers to conducting exposure. Well, so what has been shown in the literature is that there aren't too many limitations on conditions where you can do exposure. One of the things that you should always do, and this is true for, I feel this way for panic in general, regardless of whether there is a presenting medical issue, is to just consult with the person's medical doctor. Hopefully they do have a regular medical doctor that they visit. So I understand the healthcare marketplace being what it is in the United States. If you're a US-based provider, I'm aware that we have some international folks sometimes on this. If you're a US-based provider, if the client has a regular primary care physician that they go to, I would consult with that person and make sure that it's okay. The research has shown that in general, exposure is fine with most people, that there really aren't too many medical limitations that would stand in the way of doing exposure. This includes, for example, there was a great review of the literature on exposure for women who are pregnant, where, you know, the received wisdom in the public has been like, hey, you can't do that. Well, actually, yeah, you can. There's the journal, I think it was in the Annals of Women's Health. The lead author was Joanna Arch. It was with Michelle Krask and some other members of that group. And they did a very nice detailed review of the research that shows that you can safely do exposure with women who are pregnant. I don't know how far into the third trimester you can do that. So again, medical consultation, right? Our way of really addressing this at every turn, if you have any apprehension and you think, I don't know if I can do this safely, I just say, go to a medical professional just to get clearance. You want to be able to say that you've done your due diligence. And I think that's the right thing to do. Yeah, Jillian, I'm glad you appreciated the bag demonstration. You know, I thought about that because I have such particular characteristics for how I like to do exposure that I felt like I should really show you how it goes for that. It was the one where a demonstration seemed most clear. So with all that, I appreciate you all joining me today for this live discussion about panic. For those of you that are joining via recording, again, also thank you. And I welcome any email inquiries that you have, and hope to see you guys in a couple of weeks. Take care.